YouTube channel. Today we're going to talk about your birth plan, but before we do that, go ahead and click the subscribe button and make sure to share with your friends. People ask me all the time about what they should include in their birth plan, like what's important, what's not important. So I'm going to go through basically just 4 areas of the birth plan. And so the first area is going to be demographic information that you want to always include, how you want to deliver or mode of delivery, the people you want in the room, pain control, and actually there's 5. Postpartum, what do you want to happen after delivery? Okay, so let's go through each one of those so that we can make sure that your birth plan is structured and organized. So first, we're going to talk about demographics, like what to include and what's important. And the reason that this is important is because you may not deliver at the place that you got prenatal care. So if you're on vacation or if you happen to have a family emergency and you have to go out of town for some reason, you want to make sure that you are having a very thorough birth plan so that any provider that's delivering you will be able to follow it. And the first and most important thing are your information. We want your name, we want your date of birth, we want the physician that you've been seeing for your prenatal care, and we want to know their number, okay? Their phone number and address needs to be included in that, because if you're far away, we want that provider that's going to deliver you to be able to contact that physician's office and say, hey, we have your patient here. We want to make sure that we're on the same page with the due date and anything that you anticipated would need to happen during or after the delivery. So that's very important. And then we want to make sure that you put, of course, your address, your husband or your significant other's name and contact information, and your comorbidities, okay? So if you had gestational diabetes diagnosed in the pregnancy, if you've been told you have thyroid disease, if your baby is small, if there's anything going on with your baby that you've been followed for the pregnancy, that is what we want you to list in like your pregnancy comorbidities or pregnancy complications. And that's very important because in the event that you're out of town or you're in distress and you can't communicate these things, we need to be able to have this. So I'm a big advocate for the birth plan, okay? I think that, and a lot of high-risk specialists are like, every time you have a birth plan, something's going to go wrong. Not true. A birth plan is just you thinking through the things that you want to happen at the time of your delivery, and it's getting everybody on the same page with the care. And so I encourage people to bring up the conversation about birth plans with their provider, usually somewhere in the mid-3rd trimester. So 32 weeks is a great time to bring this up. Next on your birth plan, you should be including mode of delivery, like how you want to deliver, okay? Whether you want a C-section, and some people can have a primary C-section or what's called C-section on demand, and anybody can ask for that over 39 weeks. But if you want a primary C-section or a repeat C-section, you've already had one. If you've already had a C-section and you want to do what's called a TOLAC or trial of labor after C-section, put it there as well. If you want a spontaneous vaginal delivery, put it there as well, meaning you've never had C-sections in the past and you want another spontaneous vaginal delivery. Put it there also. I say that because a lot of practices, once you've had a C-section, you always have to have C-sections. That is not against national guideline, okay? National guideline says that you can have a trial of labor after C-section if you're an adequate candidate, even with 2 prior C-sections, okay? They have to be 2 low segment transverse C-sections, meaning a side-to-side incision on the uterus, not the skin, okay? If you've had a previous classical C-section, which is an up and down incision on the uterus, not the skin, the uterus, then you cannot have a trial of labor, okay? A previous classical C-section puts you at risk for that incision coming open, that previous incision coming open, and that's called a uterine rupture, and we just can't let that happen. So if you've had a classical C-section, then you can't have a trial of labor. If you've had up to 2 low segment transverse C-sections, you are a candidate or can be a candidate, depending on your cervical exam and your pelvimetry or how your pelvis is, or like the outlet of your pelvis. So talk to your provider about whether or not their office or their practice even allows that, because some offices don't. And if you're a good candidate and they say you're a good candidate, but we don't do that, then you would have to make a decision whether you want to stay with that practice or whether you wanted to transfer to a practice that does allow a trial of labor after C-section. Everybody say hi to Harrison.
Hi.
They can't see you.
Hi.
That's my son. All right, Weasel, I got to finish.
Okay.
So the third thing that we're going to talk about is who you want in the room. This is really important. And it's also really important that you, the provider and the nurse, get on the same page, right? Because this could save you so much grief if you put this down, right? If you don't want your mother-in-law in the room at delivery, then just put, I only want my husband, or I only want my husband, my sister, or I only want my husband, my sister, and my mama in the room, okay? And that way the nurse can say, hey, we're gonna have everybody step out of the room and while we're getting her set up for a delivery, and then we'll call people back as we need them. And that way she only gets the people that you want back in the room, okay? That makes for a much more peaceful delivery, right? You do not have to suffer with people you don't want in the room, but it's really important that you let us know who you want in the room and who you don't. Likewise, if you're in danger, okay, this is why I like to talk through the birth plan. So there's a high amount of domestic violence that happens during pregnancy, and there's also times where people may have sex trafficking. The birth plan conversation is a time that you can tell your provider who you feel safe around and who you don't feel safe around, okay? In confidence, one-on-one in that office. And so that way we can document who we want in there and who we don't, and we can get you some resources to get out. But obviously, that's going to be up to you to tell us and let us know during these screening conversations and during the conversation about the birth plan. But we really do need to know who is in or out of the delivery and who you want in there while you're in labor in general. Also, some of this is going to be dependent on the policy of the hospital. Some hospitals only allow one visitor during the time of labor, one visitor inside of the OR with a C-section. Some allow two in the OR at the time of C-section. Some people allow a lot of people, everybody to be in the room with a vaginal delivery. Some only allow one. So it depends on the hospital protocol. And so you really do need to talk through this birth plan to make sure that you are not surprised by something that can't be done at the time of your labor and delivery process. Okay, the next, pain control. This is a big one, okay? There's a lot of my patients that say, I don't want an epidural. I don't want any pain medicine. And that honestly is fine. That's your prerogative. So no one is going to force an epidural. The only time I really encourage an epidural is if somebody wants to do a trial of labor after C-section, right? There's that risk, although albeit small, of the uterine rupture, even with 1 or 2 C-sections. 1 C-section, it's about 1%. 2 C-sections, 1.9% risk of that previous incision coming open. So with that, I usually encourage people, like if you know you want an epidural, go ahead and get one before you're in active labor, okay? That way, if you do need an emergency C-section, we're not having to intubate and put you to sleep. You already have an epidural in place. Otherwise, it's completely up to you whether you want an epidural or whether you just want IV pain medicine or any pain medicine at all. Now, I know that some people, and this sort of kind of in mode of delivery, whether you want vaginal delivery or C-section, some people want a vaginal delivery and they want water births as a way to control pain, right? Some hospital systems don't offer water births. So that's also something that you need to be to include in your birth plan if you want a water birth. And if you want a water birth and the hospital system doesn't allow it, then you would have to, again, make a decision about whether or not you want to go to a different system and deliver. Now, I will say there's sometimes water birth would not be recommended. If your baby is very small and needs continuous monitoring during the labor process, you don't need a water birth. There's not a way to continuously monitor you while your belly is completely submerged underwater, okay? So small babies, moms that are diabetic, or moms that have issues with high blood pressure, you need to be monitored closely. So in the event that there's a complication, it's hard to quickly get you out of a tub, okay? So that's why if you have certain comorbidities or complications during your pregnancy, even if the hospital allows for water births, you do not need one. Like you would not be a good candidate for a water birth. So you need to talk through that, like if you're even a candidate for that with your provider. Likewise, some people say, well, I'm just going to deliver at home. If you are very low risk with no issues with your baby and no comorbidities, and you live a short distance from the hospital, then maybe you are an adequate candidate for home birth if there's a provider that does them in your area. However, if you have high blood pressure, diabetes, a small baby, you have issues with bleeding complications, morbid obesity, you don't need a home birth, okay? You're not a good candidate for a home birth because you have a higher risk of needing a C-section. You have a higher risk of needing some type of medical intervention to control your diabetes or your blood pressure. And your baby has a higher risk of needing close surveillance right after delivery. So you need to talk to your provider before you would be a person that is a good candidate for a home birth, okay? And most of our midwife counterparts are very good at thoroughly screening who's very low risk and who's a candidate for a home birth and who is not, okay? But we may get into trouble if you have somebody that's acting as a lay midwife, meaning they're not a certified midwife. That's how we get into trouble, because then we don't have the appropriate selection of who needs a home birth and who does not need a home birth. Last thing you need to include on your birth plan at a bare minimum is, what do you want to do after delivery, right? Like, what do you want after delivery? Do you want the cord? Are you okay with the standard cord clamping of 30 to 60 seconds after delivery? That is standard of care. If you want to go against that standard of care, then you need to talk to your provider about what your desires are and why, and they can talk to you about whether that's something that's feasible or not. What are you doing with the afterbirth or the placenta? Are you okay with the hospital discarding it or sending it to pathology for testing? Are you wanting placental encapsulation? And does the hospital do that, or does your doula do that, or are you sending it somewhere else? So these are things that need to be very well thought of. So if you want encapsulation and you don't have a doula that does that, then you need to have already reached out to someone that does that so they can tell you how to get the placenta to them, okay? So that's very important. Things I don't recommend. So placental encapsulation, there's some studies that show that it helps with decreasing postpartum depression as well as decreasing postpartum hair loss. But then there's a lot of studies that say that there's no benefit at all. My thing is, it's not harmful, so it's, to me, up to the patient. But I don't recommend it for people that have certain complications in pregnancy, right? The placenta carries a lot of hormones. It's the hormone centerpiece of all that happens during the pregnancy. Preeclampsia is caused by hormones secreted from the placenta. Gestational diabetes is caused by hormones secreted from the placenta. So you have those conditions and you're ingesting the placenta, you can see how your blood pressures can be hard to control after delivery because you're still holding on to the hormones that cause you to have preeclampsia, or you're still holding on to the hormones that cause you to have gestational diabetes. So if you have those types of comorbidities, I do not recommend placental encapsulation. Like I say, there's not a lot of data that shows that it's something that is supportive of you, but there's not a lot of data that shows harm other than those with comorbidities. So if you don't have those type of comorbidities that's caused by hormones or the placenta, it's up to you. But you do need to make sure you spell it out because a lot of hospitals don't do placental encapsulation themselves. So you need to make sure that you have a specialist that does that or a doula that does that as well. The other thing about your postpartum care is, what do you want? When do you want to eat? When do you want to shower? What do you want to eat? Those are things you need to talk to your family about so they can be prepared to sort of help cater to you after you deliver. Altogether, that's pretty much the things that I recommend that are included in your birth plan. Those are the things for me, for a specialist, that are the most important. But some people may want to put other little things, like in addition to what you want to happen during the delivery and the type of delivery, you may want to include like the environment that you want. Like, do you want music playing? Do you want aromatherapy in the room or some type of diffuser in the room? A lot of hospital systems do offer that. So you can put the specifics of that. If you want to wear your own clothes while you're in labor, talk to your OBGYN about that. Most people are fine with that. But you need to make sure you tell them so they won't keep telling you to get into another gown. Do you want, dad cutting the cord? Do you want to be able to take pictures or videos? That's something you really need to talk about because a lot of hospitals will allow you to take pictures, but not videos. Some people don't allow photos at all. So you need to make sure that you know those protocols so that your family can be aware and not angry if the hospital doesn't allow this. But pretty much you can include any extras you want in your day. If you want a pastor to be present, to bless your baby right after delivery, like those are things that you may want to include in your birth plan so that you can talk to your provider about like who visitation and how many visitors you can have, and if this is something that can be done. So you can be as detailed as you want, but those are my 5 areas that I think are must have for the birth plan.